Good morning. Good morning. Good morning. I hope everybody can hear. Oh, this is going to be fun and interesting. Wait, let me stop this. All right. All right. I wonder. No, it doesn't work that way. Okay, never mind. Good morning. Good morning. Welcome, welcome to the tea. And as you see, I'm solo today. So, before I get started, for anybody who knows the power of prayer, I just want you all to lift up some prayers for my co-host. He's not going to be joining us today. His asthma is acting up, and thankfully, he did the right thing and went to get some medical attention. Y'all know how stubborn he is, and went to get some medical attention regarding it. So he's resting today. He won't be joining us, but we miss him. We miss him. I miss him already because I'll be doing all of the things here. So solo. It's been a while since I've done that, but we're gonna get through it. We're gonna get through it. So thank you all for joining. Let's me get started here. Monitor the comments, and so I'll be looking at the comments not only here in this platform, but also on Clubhouse. So feel free to jump right in, ask your questions, comments. But we're gonna have some good discussion today. I'm excited. I'm excited. So welcome to our Saturday morning tea, where we discuss health information, news, education, certification tips, entrepreneurship, anything that comes top of mind related to health information. I am Clarice Warner. I am the Girl with the Pearls, the founder and education director of the Professional Reimbursement Network, LLC, where coding education is key. And do you know what it takes to be a certified marketable medical coder? Really? Okay. Well, before I get to our topic today, let me give you or share with you some information on a free email course on the 5 steps to become a certified marketable medical coder.
Are you interested in medical coding, but not sure where to start and scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder.
All right, all right. So, if you are in Clubhouse and you are interested in getting more information about the 5 steps to become a certified marketable medical coder, then click the link at the top of the page. If you are joining us via YouTube, Facebook, LinkedIn, or you're watching the replay, feel free to look in the description box and there is a link for you there. So today, I know it's the holiday time, and most people have a lot of things to do around the holiday time, me included. But we're spilling some hot off the press tea today. So I got it the other day and I started to talk about it and I said, no, I'll wait for Saturday. I'll spill that tea on Saturday. So, let me just remind you that if you are on Clubhouse and you want to join in and add to the conversation, just raise your hand. I'll be monitoring it. If you're in the chat, and I don't know if I'll be able to do that part, but so just raise your hand and you can say, hey, I left a comment, and I'll check your comment and read it if you're shy and don't want to talk. um, but your opinion matters and is welcomed here. And this is where we have a conversation. Conversation about things related to our profession, health information, or just healthcare in general. So for my Facebook, YouTube, and LinkedIn friends, you know what to do. You use the chat. If you have a specific question, just make sure you put a Q in front of your question so that I know it is actually a question and I don't want to miss it. So let's get into it. So for those who are joining us today, we're talking about APIs and HIM. Now, you may ask, well, what in the world is an API? Because when I first saw it, I asked that very same question. What is an API? Well, an API stands for Application Programming Interface. And In the context of APIs, the word application refers to any software with a distinct function. So we're going to dive into the world of data. Interface can be thought of as a contract of service between two different applications. So this contract defines how the two communicate with each other using requests and responses. So API documentation contains information on how developers are to structure those requests and responses. APIs are needed to bring applications together in order to perform a design function built around sharing data and executing predefined processes. So they work somewhat like the middleman. We always trying to get rid of the middleman, but I think we need this middleman. So they work as the middleman, allowing developers to build new programmatic interactions between the various applications people and businesses use on a daily basis. So it sounds like something that is a win-win. Sounds like it's something good. Sounds like something that we may need. Okay, so if you're watching me, viewing me, I'm about to share my screen. If you're in Clubhouse, you'll hear me talk about the information. So CMS released a document regarding APIs and HIM. So let me share that for you today. Okay. Yes. All right. Make sure that the screen was shared. So this information is about a proposed rule advancing interoperability and improving prior authorization processes. So I have a friend that's in the room that's been talking about prior authorization for a minute. So hopefully this is something that will be helpful for her as well. So this proposed rule is CMS 0057P, and they released the fact sheet. CMS released the fact sheet, but I'm also going to give you some information because AHIMA released some things as well. So CMS wanting to provide some information to everybody about what is happening and wanting to advance their goals around interoperability and tackling any process challenges that folks are having relating to prior authorization and to increase efficiencies in healthcare. So they are trying to be proactive and on the ball relating to this. And so these proposals will place new requirements. There are going to be requirements on Medicare Advantage organizations, state Medicaid and CHIP fee-for-service programs, Medicaid managed care plans, and CHIP managed care entities, as well as qualified health plans or QHPs, issuers on the federally facilitated exchanges or FFEs, collectively known as impacted payers. And they're going to be required to improve the electronic exchange of healthcare data and streamline processes related to prior authorization. So, to encourage providers to adopt the electronic prior authorization processes, this proposed rule will also add a new measure for eligible hospitals and critical access hospitals under the Medicare Promoting Interoperability Program and for merit-based incentive payment systems, or MIPS, eligible clinicians under the Promoting Interoperability Performance category of MIPS. All that to say, they're going to be requiring some things around APIs. And so there are 5 key provisions and 5 requests for information. And they're in the since it's a proposed rule, they're in the comment stage. So this is where you get the information, and then you can also provide commentary or ask questions, or say, yay, this is a great thing that you guys are doing, or no, this may blow up, and here's some reasons why. So they're always looking for public commenters. So um, let's see, proposal, patient access application programming interface. And again, that's API. So they finalized a policy to require certain impacted payers, and that's what all those people were that I mentioned before, to implement a health level 7 or HL7 fast healthcare interoperability resources, and that's FHIR. So if you've heard that term, it's FHIR, FHIR. Again, that's fast healthcare interoperability resources. Patient Access API. So this rule, starting January 1st, 2026, via the already established Patient Access API, they are proposing to require the regulated payers to include information about patients' prior authorization decisions to help patients better understand their payers' prior authorization process and its impact on their care. This proposed rule would also require impacted payers to report annual metrics to CMS about patient use of the Patient Access API. Then there is a Provider Access API. And in order to better facilitate coordination of care and support movement toward value-based payment models, CMS is proposing to require impacted payers to build and maintain a Provider Access API to share patient data with in-network providers with whom the patient has a treatment relationship. They are proposing that they make patient claims and encounter data, excluding cost information, data elements identified in the United States Core Data for Interoperability version 1, and prior authorization requests and decisions available to in-network providers beginning January 1, 2026. As this data would be shared upon the provider's request, they are also proposing to require payers to provide a mechanisms for patients to opt out of making their data available to providers through this API. So there's two things going on here. There's one, an opportunity for providers to request information and also provide this information. But two, patients can opt out. And so if a provider is requesting information on a particular patient that has opted out, they can't get that information. The other thing is payer-to-payer data exchange on FHIR. In the interoperability and patient access final rule, which is 85 Federal Register 25510, CMS required that at a patient's request, certain impacted payers must exchange certain patient health information and maintain that information, thus creating a longitudinal health record for the patient that is maintained with their current payer. While CMS encouraged payers to use an FHIR API for this data exchange, they didn't require it. However, in December 2021, CMS announced enforcement discretion for this policy until identified implementation challenges could be addressed in future rulemaking. And so they seek to address those challenges in this proposed rule. So in an effort to ensure a patient's data can follow them throughout their healthcare journey, CMS is proposing to require that payers would exchange patient data when a patient changes health plans with the patient's permission. Those data would include claims and encounter data, excluding cost information, data elements identified in the US CDI version 1, and prior authorization requests and decisions. For all impacted payers, CMS is considering a proposal that will require this exchange only if the patient opts in to data sharing. And finally, they are proposing that if an enrollee has concurrent coverage with 2 or more payers, that these impacted payers must make the enrollee's data available to the concurrent payer at least quarterly. Yeah, so they're streamlining some things for the patients and making the data flow a little better. Okay. Now, here's the improving prior authorization processes. So prior authorization is an administrative process that oftentimes gives people headaches, but it's used in healthcare for providers to request approval from payers to provide items or services. The prior authorization request is made before those medical items or services are rendered. While prior authorization has a role in healthcare in that it can ensure that covered items and services are medically necessary and covered. Good morning. I just saw somebody peep it. I'm sorry. So while prior authorization has a role in healthcare, it in that it can ensure that covered items and services are medically necessary and covered by the payer, patients, providers, and payers alike have experienced burden from the process. Miss Nicole, you know about that burden, don't you? And it has also been identified as a major source of provider burnout and can become a health risk for patients if inefficiencies in the process cause care to be delayed, right? Providers expend resources on staff to identify prior authorization requirements that vary across payers and navigate the submission and approval processes, which could otherwise be directed to clinical care. Patients may unnecessarily pay out of pocket or abandon treatment altogether when prior authorization is delayed. So, in an attempt to alleviate some of the burden of prior authorization processes and to improve the patient experience, CMS are proposing a number of policies to make the prior authorization process more efficient and transparent. So, first, they have prior authorization requirements, documentation, and decision, and they're calling it a PARD or PARDD. I'm going to call it PARD. We'll hear what it actually will sound like later on. API. So they're requesting or proposing to require impacted payers to build and maintain a FHIR API, and that's that PARD API that would automate the process for providers to determine whether a prior authorization is required, identify prior authorization information and documentation requirements, as well as facilitate the exchange of prior authorization requests and decisions from their electronic health records, EHRs, or practice management system. We note that under HIPAA, covered entities that are required to use the current adopted standard for prior authorization transactions, which is the X12278 version 5010. This proposed rule does not propose to modify the HIPAA rules in any way, nor would they hinder the use of that standard. The next is denial reason. CMS is proposing to require impacted payers to include a specific reason when they deny a prior authorization request, regardless of the method used to send the prior authorization decision, to both facilitate better communication and understanding between the provider and payer, and, if necessary, a successful resubmission of the prior authorization request. Prior authorization time frames. They are proposing to require impacted payers, not including QHP issuers of the FFEs, and we talked about that earlier, to send prior authorization decisions within 72 hours for expedited, i.e., urgent requests, and 7 calendar days for standard or non urgent requests. They are, however, also seeking comment on alternative timeframes with shorter turnaround times. For example, 48 hours for expedited requests and 5 calendar days for standard requests. Again, they are seeking comments. So if you have any experience or anything that you want to weigh in on related to what you think should be optimal turnaround times, now is the time to get your information in, and now's the time to provide your comment. And trust me, they have staff. They read all of those comments, and they usually post the comment. They might not necessarily say where the comment comes from, but they will post the comments and answer them, unless they're all the same and they're collective, and they'll say, hey, so many people also agreed that, say, for example, 48 hours for expedited requests and 5 calendar days should be the standard. They'll do it collectively, but they do read all of them. The next thing is prior authorization metrics. They are proposing to require impacted payers to publicly report certain prior authorization metrics by posting them directly on the payer's website or via publicly accessible hyperlinks on an annual basis. So, if finalized, these prior authorization policies would take effect January 1st, 2026, with the initial set of metrics proposed to be reported by March 31st, 2026. And then, if you are into CAUS, the electronic prior authorization measure for MIPS, eligible clinicians and hospitals for CAUS. They are proposing a new electronic prior authorization measure for MIPS eligible clinicians under the Promoting Interoperability Performance category of MIPS, as well as the eligible hospital and critical access hospitals under the Medicare Promoting Interoperability Program. To meet the measure, a prior authorization must be requested electronically from the PARD API using data from certified EHR technology, or the CEHRT. And there's probably a way to say that as well. I just don't know. I'm not in the data sphere. Under this proposal, MIPS eligible clinicians, eligible hospitals, and CAUS would be required to report the number of prior authorizations for medical items and services, excluding drugs, that are requested electronically from a PARD API using data from the CEHRT. Let's see. Interoperability standards for APIs. In the December 2020 CMS Interoperability and Prior Authorization Proposed Rule, CMS proposed to require the use of certain implementation guides, or IGs, for the implementation of the APIs in that proposed rule. So after careful consideration of these IGs, their development cycles, and CMS's role in advancing interoperability and supporting innovation, CMS believes that while these IGs will continue to play a critical role in supporting interoperability, they're not ready to propose them as a requirement. So that's going away. These IGs will continue to be refined over time as stakeholders have the opportunity to test and implement their new technology. They will continue to monitor and evaluate the development of the IGs and for future rulemaking consideration. Therefore, while they are strongly recommending payers use certain IGs for patient access, provider access, payer-to-payer, and PARD APIs, they are not proposing to require their use. Also, requests for information, or RFIs. Accelerating the adoption of standards related to social risk factor data. They are reissuing their requests for information on barriers to adopting standards and opportunities to accelerate adoption of standards related to social risk data. CMS recognizes that social risk factors, example, housing instability, food insecurity, influence patient health and healthcare utilization. And so they further understand that providers in value-based payment arrangements rely on comprehensive, high-quality social risk data. So given the importance of these data, CMS looks to understand how to better standardize and liberate these data. There's another comment section right there. Electronic exchange of behavioral health information. CMS is also reissuing their requests for information to inform potential future rulemaking on how to advance electronic data exchange among behavioral health providers. They seek comment on how CMS might leverage APIs or other solutions to facilitate electronic data exchange with behavioral health providers who have lagged behind other provider types in EHR adoption. Improving the electronic exchange of information in Medicare fee-for-service. In the Medicare fee-for-service program, the ordering provider or supplier can often be different from the rendering provider or supplier of items or services. We all know this, which creates unique obstacles to the coordination of patient care and exchange of medical information needed to ensure accurate and timely payment. CMS seeks comment on how Medicare fee-for-service might best support improvements to the exchange of medical documentation between and among providers, suppliers, and patients, as well as how they might best inform and support the movement and consistency of health data to providers for their use to inform care and treat patients. Advancing the Trusted Exchange Framework and Comment Agreement, or TEF, I think it's called TEFCA. Earlier this year, the Office of the National Coordinator for Health IT, or ONC, announced the release of the Trusted Exchange Framework and Common Agreement, or TEFCA version 1. They believe that the ability for stakeholders to connect to networks enabling exchange under TEFCA can support and advance the payer requirements that CMS proposed in this rule. CMS seeks comment on how enabling exchange under TEFCA can support these proposals, as well as policies in the CMS interoperability and patient access final rule. They also seek comment on their approach to incentivizing incentivizing, you know what that means, where the money resides, or encouraging payers to enable exchange under TEFCA. And then they have advancing interoperability and improving prior authorization processes for maternal health. The Biden-Harris administration has prioritized addressing the nation's maternity care crisis. And yes, we have a maternal care crisis in our country. It's bananas. In my work in classes for public health, you would be amazed at what the numbers look like in our country compared to other countries that are similar to us in resources. There are some countries that have lower resources who have way better maternity health numbers than we do. So there's a lot of work around this. I'm sorry, I did a soapbox moment, didn't I? But there's a lot of work around this. But anyway, with both the White House and CMS issuing their coordinated approaches to addressing the crisis, CMS seeks comment from the public on evidence-based policies we could pursue that leverage health IT, data sharing, and interoperability to improve maternal health outcomes. And let me also say, back on my soapbox, that unfortunately the maternity health mortality rates are higher in our Black and Brown communities. And so any help related to this would help the numbers are staggering across the board, but in our Black and Brown communities, they are even higher. And any information or any innovation that can come of this to help us alleviate those numbers and help in maternity care would be welcome. So CMS also seeks comment on leveraging the USCDI to address maternal health, as well as improving prior authorization policies that can negatively impact maternal health outcomes. So that is what is going on, and sharing the hot off the press tea with you regarding that. Okay. I also wanted to show you what I received and what you should receive. So if you are a member of AHIMA and connected to your state, local, or state organization, association, you, if not this past week, in the coming weeks, should receive this information as well. And let me see. Okay. So AHIMA sent this out to the advocacy group, and it pretty much talks about all the information that I just mentioned from CMS on the advancing interoperability and improving prior authorization processes proposed rule. The one thing that I wanted to mention in here that I hadn't seen anywhere else was that the comments for the proposed rule are due March 13th. So you have until March 13th, 2023 to put together some comments. However, if you are part of AHIMA or not, I don't even think you have to be part of AHIMA, possibly. But if you want to get involved in work groups to formulate the comments, because they're all over the place, and here's an opportunity to work with others and put your comments to together with others and collaborate on with different organizations across healthcare, and to allow collectively your comments to be added to the CMS proposed rule. Join the AHIMA work group, and you can contact the Policy and Government Affairs team, and they are at advocacy@ahima.org. Not only do they put information like this out when they are commenting, but they're also working on commenting on other proposed rules or other regulations that may be coming down the pike. So if this is one that maybe you don't necessarily have an interest in or don't have comments on, you can still reach out to them and get involved. It takes a village, y'all. It takes a village. So the more, the merrier. So with that, I'll stop sharing my screen here, and let's see what we're talking about. Any comments? Any questions? Okay, let's see. Nicole, you said opting in shouldn't be an option, just nosy dressed up like it's helpful. I'm trying to follow. I don't know if you're still in the room. Are you still in the room? Yes. You want to expand on your comment there, ma'am?
Can you hear me?
I can hear you.
Sorry, I'm just with you.
I'm sorry. My bad.
If they switch to another insurance provider, that the client has the option of opting in to share their information. Why do you need the information from a previous insurance carrier? You're being nosy. And that's an opportunity to prejudge, and no, I don't like that. That was it. That was the one that caught me.
So wouldn't you need that information to, so if they've already received the care, wouldn't you need that information to know that, or no?
No, if I'm going to another insurance, you don't do that with your car insurance or your house insurance. Like this, how many times did you use it before? Like, what information is it that they want? It's like they're making it such that if you want to receive my care, if you want to receive payment, then you have to do this. It's kind of like making the patient feel like they don't have an option. So I'll give you an example. I recently went to get a procedure, and I asked what was the self-pay. And the self-pay was less than what the insurance would charge and my copay. So I was able to just go ahead and pay it. But if you want your insurance to pay it, then it's like, okay, you have to sign away all of this information. I just don't like the information, the if you want this, do that. Sharing the client's information, that I don't like. I just think it's dressed up, being nosy, and then you can make judgment about how much care you're going to give to the client and cut them off. I don't like that.
So you're saying it's making judgment from the provider perspective or from the payer perspective?
The payer.
Okay.
The payer, because then they have the option. I'm not saying they're doing it. If this is something new, we don't know exactly what they're going to do.
Correct.
But why do you need to know what was going on, what care I received, how much the previous insurance carrier that I had? Why do you need to know any of that information?
But what if they don't have that information from the provider? So
I guess what I'm saying is, let's say that I was receiving a certain type of care from, and I had United Healthcare, and then I decided to switch to, I don't know, Care Source.
Okay.
Why does Care Source need to know what services I received when I had United Healthcare? That's all I'm saying. I don't like that. You don't need to know that I, had weight loss surgery and whatever the case may be. You don't need to know the details of whatever. You don't need to know that I had, a pelvic exam and whatever. Like you don't need. It's so much. It's just so much information that's moving from being private. I just don't like it. It's just my preference. It's just from a nursing perspective. If you're gonna pay for, if I'm paying the insurance for you to cover what I need covered, why do you need to know? I'm not saying you don't need to know the history, but the way I understood it, and maybe I didn't hear everything that you said, but the way I understood it was the patient has the option to opt into sharing previous data from a previous insurance that they had before.
Right. The patient has the option to either opt in or opt out. They can opt out.
Right. They have that right. They can opt out now. But in times past, when they have that opt in, opt out, eventually it becomes mandatory. It's a little trick.
Well, I mean, and they can. Yes, you're absolutely correct about that. They can craft it as to, well, if you are opting out, then this may not be the carrier for you, which forces you to have to seek another carrier for your services. So yeah, you're right. You're right about that. You're right.
Yeah,
about
that's my soapbox for this morning.
Well, we all have them. Thank you for. I just wanted to make sure I got it. Enjoy the gym, ma'am. Enjoy the gym. Yeah. So that's from a nursing perspective. She gave her thoughts and comments on the patient opting in, opting out from having one payer get information from the other payer, or exchanging the patient information between the payers. That's the payer-to-payer data exchange API. So yeah, this was the hot off the press information from CMS in the CMS 0057-P proposed rule. I think it actually will print in the final register. I think I read somewhere that it's going to print on the 13th. So you guys are getting it a little early. Yay. If you hadn't seen this already. All right. So that is all I have for today. If you have any questions or want to join in on conversations, or have any other things that you want to address around health information, feel free to raise your hand. I'll get you in. Again, I'm trying to check comments and seeing what's happening out here. Good morning to all of my folks here on Clubhouse. Hi, Tanika. Hi, Shay. Hi. I don't know exactly what your Care Connect Home Health. Hello. How are you? Welcome. Let's see. And Nina, how are you? Welcome. Yeah. So it's been a wonderful day in these healthcare streets, a wonderful week in this healthcare streets. I just think, we've talked about several times the importance of data and the importance of the various roles that we as health information professionals play around data. So oftentimes people like to pigeonhole the health information. I just had this conversation the other day. They like to pigeonhole the health information to just reimbursement, but it's really bigger than that. As health information professionals, we are the keepers and protectors and stores of health of our patients' health information. It's our job to make sure that it's accurate, that it's correct, that it's shared properly and correctly. So I think we as an organization, as a profession, definitely should weigh in on all things related to health information. And again, not just on reimbursement matters, but things that impact the information um, flow and processes of data. So again, when we looked at the health information career map, we saw that there were a few new uh, jobs or career paths that directed folks who are interested in the data realm, data analysis, and all of those things. So this is just one of those pieces of information that can maybe help you decide, hey, I'm interested in health information. I may not necessarily care about coding. I may not necessarily care about um, uh, any of the reimbursement portions of health information. I'm concerned about protecting data. I'm concerned about privacy and security. I'm concerned about all of the things data analysis. And so here is an opportunity to kind of look through and see, well, what's out there, what's coming down the pike, and being prepared. Um, Immersing yourself into the information that is coming down from the ONC. I think I mentioned last week a little tea that I spilled that HIPAA is about to change. There's about to be some changes in HIPAA, y'all. So buckle up, Buttercup, because it's coming down the pike. And so you need to be prepared. Um, being proactive versus reactive, being in the know, getting to understand, hey, well, what's happening? Well, what are they talking about? Well, what is this? I know I heard at the AHEMA 22, I heard people talking about fire, and I'm like, fire? What is fire? So I began to look and research and understand. It's like, okay, let's see how this is coming together. There's a lot of talk in the data space and health IT space. And while a lot of it is like these APIs and software integration and interoperability, it's about the patient data, though. It's about the health information. And so that's where we come into play. And that's where we need to make sure that we are um, providing our comments. We're in the room, we're having those discussions, we're getting the understanding of what is happening. And then, once we, of course, get the understanding, it's also our job to make sure we educate and inform and let folks, our patients, know, because they may not necessarily understand and know. Even to Nicole's point, they may not necessarily know and understand, what this means for their health data and how their health data can now be used behind the scenes for XYZ. So again, I just wanted to bring this information to your attention, knowing that it's out here. If you're interested in joining the work groups to comment, feel free to do so. Yeah, all of those good things. So y'all quiet today. I know we don't have Mr. Jesse here to spill that tea, but I know he would be would have a lot to say as well. And I'll check in on him. But again, just wanted to provide you some information and spill that tea. So no comment. I hear dead space and air. Sorry I came in late. I have to rewatch to understand it better. No problem. I appreciate that. I appreciate that. We were talking about CMS proposed rule regarding advancing interoperability and improving prior authorization processes. And me personally, I think that prior authorization thing is really, really big in most of the spaces that I'm working in, behavioral health, and even to their point about maternal health. That's huge. That's huge. And being able to finally put some teeth around that. I mean, these payers are they're kind of rogue out here in these streets because they know where the money resides. They are the keepers of the bag. And but we pay to we pay for health services, and understanding and knowing what they will and will not pay and why is important. So having these requirements placed on them to explain why they're not paying things as they should, etc., will be key. So I'm excited about what comes, the work that comes, or the comments that come from this. I'll be looking for this to see what the final rule, because they start with the proposed rule. You get your comments. Everybody looks at everything. They make some decisions and decide and determine, and then a final rule comes out. So I'll be interested to see what the final rule of this law looks like in the coming months, years. So I think it's in 2026. So interesting.
Clarice, may I say something?
Yes, you may.
In regards to prior authorization, this is just, I just want this on the recording just for anybody else who comes to listen. There are people who don't understand the prior authorization process, and I think it is one of the contributors to non-compliance with healthcare, because it can be very, very difficult. And I had a situation with my father here recently where the pharmacy was trying to charge $900 for a specific medication because it didn't have a prior authorization. And this medication, he's been on it for 5 years, but now things have changed. He's 85, he doesn't understand the process. And because I'm a nurse, I had a little more patience to deal with calling back and forth and, calling the doctor's office and calling the insurance company. And then they didn't fax this over, and one of them's waiting on the other one, and, so on and so forth. So I just want to encourage everybody to ensure that you are paying attention to your family members, your neighbors, just people that you care about, and be their advocate. If you have a younger mind, if you are patient, if you feel like that you understand the process, or maybe you don't understand the process, but you have the patience to read and be on the phone and help. We need to help our communities when it comes to this prior authorization, because as a nurse, I find that frustration and confusion causes people to do nothing. They just give up, and then they become non-compliant, and then their health is at risk, and then it becomes a domino effect, and it's not their fault. It's this prior authorization procedure. And I don't have a suggestion as to how to fix it, or, prior authorization, because that's out of my scope. But what I can say is we need to become better patient advocates for our community, for people we love. Just keep our ears to the ground when you hear somebody say something. My grandmother didn't get her medicine, or the pharmacy did this, or the doctor said that. Like, keep your ear to the ground if you're a person who has the patience to help, to do something, make a phone call, or that press 1, press 2, listening to music and all that. That's frustrating for a senior or somebody who has a deficit, a hearing deficit, or a visual impairment, or whatever, taking a lot of medication. It is frustrating, and it can cause a person to become non-compliant. I'm getting off my soapbox. I feel my mic.
So I appreciate you. Even if you're not the patient person, but you still have these experiences, connect with the patient person, because to your point, we need to know. We definitely need to know. And well, you and I have talked a lot about these managed care programs, and I just feel like in working with seniors, I just feel like, seniors and underserved, I just feel like they're preying on them. It's so much, they're dangling these carrots. Oh, you can get, I heard all of these conversations during the enrollment, and every time I heard what, I'm like, are you kidding me? And so yeah, you're dangling these carrots and you can get X amount of things, but what are you losing, or what are you missing, or what is the difference or the variance from the insurance that you currently have versus what you think you're going to get, because they're giving you a right now trinket. That right now trinket won't help you when they deny XYZ, that the current insurance company that you have and built the relationship pays for. So again, it's starting all over. It's learning, and believe it or not necessarily with the elderly, but with some other folks, they insurance hop. It's an incentive. Oh, they giving this month. Well, let me go jump over here and get this from them because this is what they giving this month. Oh, I heard they giving so and so and so, and they having these conversations about what somebody else is getting. Oh, girl, you could get some shoes. They allowing you a voucher to get $50 worth of shoes on this, that, and the third. So folks will jump over. Oh, I bet. So that becomes the conversation, and folks will jump over there and get those shoes until they hear about what the new trinket is or the new carrot is from the next provider. It is bananas, and it is a managing nightmare. Even on the provider side, because depending on the type of services that you provide, you can't keep up with that. You imagine the person who has to do the billing. Lord, help your hearts. You have to make sure that you're always, and that's why that front end process is so important. Yes, every single time, depending on the population or not, it really doesn't even matter the population because anybody could do it. Always verify, or I need to see a copy of your insurance card. That is the primary reason. I need to see the current copy of your insurance card and making sure that they are still insured with that particular payer. Otherwise, downstream, you have given all this beautiful service. You've given everything you got in the y'all know I hear a song, Anita Baker, giving you the best I got, gave you the best that I got as far as services, and now you're not going to get paid. Why? Because the patient then jumped the ship with the different insurance, and sometimes they remember, sometimes they don't even know. Like, oh yeah, you're right. I did. This ain't even my right card. Oh, my card. I haven't even got the new card yet. Whatever, because they've jumped ship based on whatever trinkets that are out there. So yeah, we have some work to do from a patient advocate perspective. You are absolutely right. And even as providers of health services, oftentimes it helps us help them, by providing them the necessary information, because sometimes we know we've encountered situations that, multiple times with multiple patients that we can then begin to share with others. Hey, I know you have this insurance. I know, you have this condition. These are some things that you may want to make sure that you're navigating. These are some things you may want to be on the lookout for. If the provider is considering prescribing certain services or medications or prescriptions, I mean, the provider, the actual provider, the rendering provider themselves may not have that knowledge, but the office has that knowledge. The person in reimbursement in that office may have that knowledge, that they can put together maybe a fact sheet or FAQ or something, or have conversations or be available. Hey, if you have questions about your insurance or whatever, have a conversation with the person in our billing office. They may be able to guide you or help you. That's patient satisfaction 101 all day. This provides you an opportunity to engage with, relate with, and to Nicole's point, allow your patient to be compliant with the treatment that you're prescribing. So we all have to work at this together. It's a village that we all need to really work with. So I appreciate your comments, Nicole. Thank you very much for sharing. If anybody else wants to weigh in, if you're on Clubhouse, y'all know I'm by myself, so I'm looking and see. Okay. Just, raise your hand and I will definitely bring you up to the stage. And if you are on the other platforms, you can just put your questions or comments in the chat. I will definitely make sure that I get you in. Okay. Well, I think this was actually a good conversation. I think it was eye-opening for me there. I got some nuggets and I learned some things. I hope you learned some things as well, related to what is coming down the pike, and how we can help advocate for our community as it relates to healthcare. You are so welcome. She says, thank you, Clarice, and others who have spilled some tea today. Thank you. Thank you. Thank you for engaging. Thank you for being here. Thank you for sharing your experiences. Again, don't be shy. Come on. You can talk to me. We're learning here all together. And so I appreciate you joining me this morning and joining us for the Saturday morning tea. Hopefully the tea was spilled. I'll ask, was the tea spilled? Was the tea spilled? I believe I had one taker who said, yes, there was some tea spilled today. So I appreciate that. If this information was valuable for you, help us share this message with others. So one thing that I have learned in the last couple of weeks, it's about sharing. So sharing the video helps expand the reach. While liking the video helps and commenting on the video helps, I appreciate it all, but sharing the video actually gets that message to others. And so my understanding, it tells the algorithm that, hey, this is something that's important that people need to know. So share it. Even if you share it with one, share it with a couple, put it in a group, wherever, however, I'm open to it all. Just share the message again, because others may need to know this information. And then you can also subscribe to the channel, the Professional Reimbursement Network. We're at PRN Coding EDU. So subscribe to the channel where I provide not only the information here regarding our Saturday morning tea, which you can also see on Facebook and LinkedIn, but I also post other comments and videos related to health information, things that you may need to know to help you if you're in the reimbursement sphere, specifically around medical coding, that you may need to know to become a certified marketable medical coder. Last but not least, to my Clubhouse folks, make sure you click on the green house. Come on and join us, join in on the fun in our club. And of course, you'll get notified of our live broadcast. And we are here Saturday mornings at 9 a.m. Eastern Standard Time. So this has been a great session today. Thank you all for joining. And remember, be safe, be kind, and don't wish for it, work for it. Until next week, have a great weekend and take care.